So I want to introduce Dr. Shannon Beres, who is a pediatric and adult neuro-ophthalmologist and my partner in crime at Stanford. It's been a privilege and honor to collaborate on optic disc drusen as well to share many, many patients. Dr. Beres.
Great, thank you, Dr. Liao. Well, that could not have been a better segue for sure. So today I'm going to change gears a little bit and talk about sorry, this is what happens when you're short. Okay, so we're going to change gears a little bit here and talk about the beginning of optic disc drusen and what happens in pediatrics. So I'm a pediatric neuro-ophthalmologist, and this is bread and butter for us in terms of what we see. So the purpose of today is going to be to understand the vast differences in feasibility of imaging young children and adults, and to recognize the imaging opportunities that we do have in children. And we'll talk a little bit about the feasibility of that. So this is the challenge. This is what we've seen from the photos that Dr. Liao and Dr. Hammond have shown. What is this? Is this papilledema? Is this pseudopapilledema? And this is our biggest problem. I bring you back to our clinic where they come in for a particular headache or just needing glasses. And then this shows up when they look in the back of the eye. And of course, this is a gut-wrenching first moment of any optometrist out there in the local community about, oh no, am I the first person to say this patient has a brain tumor? And this is what we see in the pediatrics, different than the beautiful photos that Dr. Liao and Dr. Hammond presented. You don't see the drusen here. They just look like swollen nerves. So I'll start this off with an illustrative case of a 12-year-old with headaches, as Dr. Liao said. Sometimes they just come in with headaches, or Dr. Hammond did. And this is a patient of mine. She came in because she had headaches since middle school. She'd been followed by for optic nerve swelling since the age of 6 at an outside eye clinic. But she'd had a full workup, and the workup was negative. Nobody had ever mentioned optic disc drusen for this patient, other than just she had abnormal appearing optic nerves. And she didn't have any vision complaints. Just the fact that she had the headache is what kept bringing her back to the eye doctor. Her vision was perfect, 20/20 in both eye, normal color vision, really no concerns other than what the back of the eyes look like. And this is what they look like. On the right eye, you can see this hyperemic with complete blurring of the nasal border. But the temporal border is clear. There's a little bit of obscuration of the small vessels, the small diameter vessels. In the left eye, you can see the same with 360 degrees of blurring. This is not a beautiful picture. This doesn't have any drusen, little tapioca pudding looking like things. And she's complaining of headaches. She's had this for years. So what do? Do we put them on the Tour de France of the photo suite? Do we do a B-scan ultrasound, an OCT, an autofluorescence, a visual field? It's a 12-year-old, so how long can they really sit for all of this? As a provider, how worried are we? So for her, we went through with doing a visual field as we think about a vital sign of ophthalmology, and she does have a little bit of visual field defect. That wasn't present prior. And I look at her OCT, and her OCT is very reassuring in terms of the average retinal nerve fiber layer. So I say, let's just continue on. Let's keep watching. So if I was worried, I would consider a brain MRI, an MRV, a lumbar puncture, and getting labs for her. If I wasn't worried, I would say, let's watch and wait. 4 to 12-week follow-up. Let's see what happens, which is what I chose to do in this case. So she comes back 4 months later, and now we have an increase in elevation of the optic nerve fiber layer. She's moved from the 110s to 135s. Is that significant? Well, maybe it's segmentation error. Maybe going back to the original and figuring out, is this truly segmentation changes? Or am I missing something? Clearly the nerve looks more swollen. What do we think? Are we worried? Are we not? But I go back to her prior history and I look to see how there's been fluctuation of her OCT. Now, of course, this was done in an outside hospital, so I cannot go back and look at the segmentation myself to make sure that that the automated segmentation is not sort of skewed and spurious. But you can see these fluctuations that she's had over time. And I would like to say for purposes that this is real. And what are these? But she's clearly developed new visual field defects. So unfortunately, this was the workup she had before this. She's had 5 lumbar punctures. These are when she was less than 12 years old, which requires anesthesia. She's gone through multiple headache medications because nobody knows what this is. Part of this is being on Diamox. So what do we do? Why is she having these fluctuations? So we'll bring this up at the end of the talk. So could any of this have been avoided? Is there any way we could figure out how to image pseudopapilledema, feel confident this is pseudopapilledema, and not go through this whole workup that she's gone through multiple times every time she comes back for headaches? So take 2, her sister shows up in clinic. Now this is 2 years later, and she shows up at clinic, and she also has retinal nerve fiber layer thickening, as you can see here in the right eye, very asymmetric, making me really think that this is going to be drusen. But she comes back 2 years later, and you can even see in the photos, the fundus photography there, that we see now a swelling of the nerve, and we also see visual field defects that have increased over time. And they're pretty reliable. You can see how it has changed over time. So what is this? Do we worry about this, about her? So to be honest, we didn't actually do anything for the sister. I didn't even image her because I felt confident this was drusen. Not because I necessarily look at this picture and go, oh yeah, that's drusen, but because I have the history of the sister and because I also have seen this asymmetry and I felt comfortable just following her. So this is the challenge we have, is this pseudopapilledema versus papilledema. This is a very different challenge that we have in the pediatric realm and not in the adult side, as I also see adults 2 days a week. So we look at these variations in swelling in the young, and we wonder, may they be the reason for pseudopapilledema? What are these variations that are happening? Why do all of a sudden these disc drusen eyes swell for short periods of time? So Melinda Chang and a paper with Dr. Pinellas determined that misdiagnosis by using one modality of imaging in kids with pseudopapilledema was found. And then Dr. Jiao found that you needed actually multiple modalities were needed to identify drusen in his 2020 paper. So, and then lastly, the most recent paper here is by Michael Wan's group, who recently published a retrospective study of 41 eyes with optic disc drusen and 21 eyes with papilledema in the Canadian Journal of Ophthalmology. And they found that, that when they looked at the differences on the OCT, that was really the way to determine the difference between pseudopapilledema and papilledema. So it's paramount that we do rely on this test with high sensitivity for optic disc drusen. We also want to make sure that this is high sensitivity for papilledema because we do not want to miss papilledema. I'll talk a little bit more about that study in a bit. So we can't really continue forward without talking about what actually happens in children. What happens with the growth of the eye? What is actually happening to create this crowding that is going on? So here you guys can see the differences that in axial length, there's a growth of the eye from birth, a very rapid growth until the age of about 2 to 5 years old. And then all the way up to age 13 is when we finally see that the axial length of the eye is about the same as an adult. When you think of the optic nerve, the optic disc and nerve growth, we think by about 1 year of age, they actually might have, 95% of them will have the size of the eye of an adult. Looking at the scleral opening, between 11 and a 12-year-old on, we think that the scleral opening is the same as in an adult. So how does this change in their lifetime between the ages of 6 and 12 years old? What is actually changing during that time? So looking at Bruch's membrane and looking at using OCT to figure this out would help us. So in these post-mortem studies by Rimmer in 1993 at UCLA, they measured the optic disc vertical and horizontal diameters and the retrobulbar optic nerve measured within 2 millimeters of the posterior globe of 95 children on autopsy studies between the ages of 4 months and 20 years of age. So by the age of 1, 80% of the optic nerves are this. 80% of the optic nerves are adult size. So even by the age of 2, we are nearly at adult size optic nerves. So this is the timeline I've put together as to just an illustrative description of what we see in pediatrics. So between the ages up until about 8, we see this sort of pseudopapilledema that kind of spans all the way up until about age 12. We generally see faintly visible drusen around that age 12, and then we see the superficial drusen and buried drusen from that point forward. the question is back in this early age group, is this when we need to start imaging to figure out what is actually happening in these crowded areas? So how can we image kids? Well, it's different than adults. Yeah, I'd love to have a 6-year-old sit for 7 minutes for an OCT scan, but that's obviously not happening. So we looked at B-scan. These are all the different studies, and you guys will have my slides after. This is bringing together sort of a literature report of all the different studies that have happened in children. And the B-scan ultrasound is really easy in kids. We can do them screaming, we can hold them down, and we can get a study. However, it's not very sensitive, although it has been the gold standard up to this point. Fluorescein angiography, obviously, is very, very difficult in children, but we have looked at that, and the paper with Dr. Pinellas and Dr. Chang actually found that the fluorescein angiography was the highest accuracy of identifying drusen in papilledema versus pseudopapilledema patients. So OCT, we've talked a lot about that, and OCT EDI, as well as what Dr. Liao just spoke about. Obviously, those are going to be the gold, at this point, are now the gold standard for both pediatric and for adults. However, how do we do that in kids? OCTA, they have to sit for quite a long time, be very, very still for us to get that type of imaging. And AO, I mean, call it off. So we'll see what we can do from this point forward. So how do we do this in kids? So this is what it looks like, obviously, as you guys see in the adult clinics. And this is actually what we can do in pediatrics. So this is myself imaging an 11-month-old baby, and we have a handheld OCT that we can do. Now, the problem with this is that we cannot do automated segmentation, and we can just do swept source. So this is what we're able to do for kids. So this is an opportunity. It also takes a long time for us to image. It takes me about anywhere from 30 minutes to 45 minutes to image a baby, to get essentially when they're looking directly at me for a long enough period of time. This is also how we can image babies. This is called the flying baby technique. I've become a master at flying baby techniques after the parents allow me to finally hold their baby. And we essentially fly them into an Optos, and we're able to get them photos. This is actually the photo of this baby. So we get lucky. We get very unlucky for many, many tries. And then if we can get them calmed down long enough, we do get lucky often, which is great, as long as we're patient. So going back to the study that we looked at, the most recent, there really hasn't been anything else published in optic disc drusen imaging for children since 2021. This is the last study. This is Dr. Wan's group up in Canada, who essentially found that the optic discs, using the spectral domain OCT, were really able to differentiate optic disc drusen from papilledema. However, in true clinic, I just don't feel like this is that helpful, because we often see these fluctuations that I talked about. This is coming from the same paper, talking about the same exact things that Dr. Hammond and Dr. Liao were talking about. We've got the hyporeflective boot-shaped areas, the signal poor regions that you can see less well in the younger that they are. We can also see the hyporeflective bands. I will have to say I see many kids with papilledema and pseudopapilledema, and looking for the hyporeflective bands has been much more difficult on my ped side than my adult. I'm not sure if that is a product of them being truly calcified as they get older, as the drusen get a little bit more mature, or is that just that our imaging technique is not as good for the kids because we can't do as many slices, given that they cannot sit as long. So I'm not quite sure the answer to that one. And then, of course, we've got a presence of one of these is suggestive of being drusen, as found from this paper, one of the 4 that have been starred. So the prelaminar hyperreflective lines we just talked about, whether or not these are able to be imaged very well in children, is a bit, I think, a product of, are we going to be able to image them long enough in order to get these? So we also see FOMs in children. This is a paper as well that was published looking at FOMs in children with pseudopapilledema without ODD. So we need to be careful that some of the things that we've talked about can be seen in both papilledema and in pseudopapilledema. So I'll bring you back to the timeline that I sort of artificially created. This is not, this is something that we see clinically. But how do we image this? If we're going to talk about really imaging these drusen from the beginning, we need to have modalities that can span their lifetime. We also need to think about how the growth of the eye happens during this time frame. And this is not different to how we do other pediatric studies. Even simple studies for amblyopia, we are challenged by the fact that the actual normative data changes as the baby gets older. It goes from 2200 vision to 2080 to 2020 throughout 4 to 5 years. So we're used to making these changes, but we've got to be comfortable with having somewhat different modalities to try and follow the drusen along the way. But with OCT, handheld OCT, we are getting a little bit closer. We're now able to actually compare using similar data points from a child. If we could image a kid from age 1 to 2 who we know has a genetic or a sibling with drusen, can we follow that drusen? There's many retinopathies where optic disc drusen is very common in those patients. Can we start with that? I have 1 to 2-year-olds that come in with incredible papilledema, pseudopapilledema. And do we just start imaging those kids from that point forward and see what happens, what develops as they get older? I go back to my last point, which is why are there these fluctuations in kids? Why do we see this? Where all of a sudden we'll see a swelling of the optic nerve. We all freak out and we're like, oh, do I re-image? What do I do? The kid has headache. So this is a couple studies that we have here, and these are all discussing whether or not these are what I call mini NIONs that are happening. Are these axons that are becoming injured and then having exoplasmic flow stasis during these periods of time that are giving us these sort of swells of pseudopapilledema that we see? And these are the studies that we've seen: a 15-year-old in 2020, a child with 11 different times of edema resolution. Yes, maybe this is automatic segmentation error. Maybe this is the problem. But I don't feel that way, given that we follow these fundus photos and they clearly look different over time. So what do we do with this? Is this what's happening? Are these mini NIONs that are happening each time we see this pseudopapilledema? Is this actually movement of drusen? Is this actually loss of axonal thickness? What is going on here and what is the trajectory? So this is the important fork in the road. What do we do? Can we just image a kid in clinic with B-scan, OCT, autofluorescence, AO? I don't know at this point. And then can we stop? Can we tell parents confidently that this is not a brain tumor and don't worry, you don't need a 2-hour anesthesia event where you take half day off your work and the kid has to recover in the post-op area and do a lumbar puncture because we have them under anesthesia, so we might as well do it right now? Can we stop that? Is there a way that we can feel confident enough to tell these kids, these parents, that we don't need to do anymore and just walk right out of clinic? So I pose those questions. I don't have great answers to them, but I'd love to have discussion with everybody about that throughout our poster session and the times between talks. But in summary, I bring up OCT EDI is the gold standard in pediatrics in adults. It is now becoming the gold standard in pediatrics. And we really need to become innovative in how we want to follow these kids, because it begins in childhood. It begins when we see them with pseudopapilledema. And then Dr. Liao was talking about, well, when an adult presents, it's like, well, why do they present to your clinic if they just have drusen? Well, they wanted glasses or they had a headache or something like that. It's very important in pediatrics because I need to know, am I going to image this kid? Am I going to get a lumbar puncture? This is a huge issue in pediatrics because this is bread and butter pediatric ophthalmology. And these are the dilemmas we have to deal with every day. So I'd love for us to become innovative, understand how to image these kids, and that might give us more information for how do these develop, how do these grow, and what are they? Thank you. I don't know if you're on. You're not on.
Yes, I'm on. So we're happy to take some questions. So for the next 2 speakers, no worries, we're going to be right on time, even though it seems like we're not. Henry.
Okay, thank you so much for your talk. I have a question. Have you observed any gender differences in the children that present with papilledema or pseudopapilledema or ODD?
No, I have not.
Yeah, great talk. Thanks. I really enjoyed that. So yeah, I agree with your hypothesis that there's these little tiny AIONs. I have a teenager that I've been following, although I haven't seen him for quite a while, but he would have these like little sectoral neurofiber layer thickening that would just come and go, and he didn't know they were happening at all. Just that on serial OCT, he would, oh, this part swole and then it went away. Then this other part was swell, then it went away. And actually, he did develop little tiny scotomas that he can kind of notice, but he doesn't really notice. And it was only in one eye, just I think in your patient. So it was pretty convincing. It wasn't like, yeah, I don't think we ever did a spinal tap in that case. So I thought that was just really interesting. I've had that same observation. And I think that, and another comment about when to image them, I had a patient who actually I sent to the optic dystrophin trial. I saw him as a teenager, and he had these tilted nerves. Well, it could just be tilted, but he had these hyperreflective lines. And I said, well, but it would be dynamic. It would be a little swollen, but he actually got calmer. Then I told his mom, well, we should maybe think about doing a spinal tap just in case because it's changing. And then his mom said, I had the same experience when I was a teenager. I saw Joe Rizzo at Harvard,
Wow.
and he sent me to the ER, and I had a spinal tap, and I had an MRI, and all the stuff. She said that was horrific. She's like, if you don't think he needs it, let's just hold off. And I just thought that was really interesting. So I imaged her as well, and she definitely has dystrophin. So I just think that was really interesting. I wish we could have that OCT from like 30 years ago when she was at Harvard to kind of see how she evolved.
That would be great. I actually have multiple times where I get the parents into the seat and I'm like, oh, hold on here, out of the queen seat, into the queen seat. I have the mom come and sit down and I take a look. So
That was great. I have follow up on Thomas' question. What do you think about the higher incidence of RP patients with ODD, and are they having these kind of AION episodes?
absolutely. So I have 5 kids that I'm following right now, and they have unbelievable swelling episodes that happen. And they're hard because they have vision loss outside, I mean, from a macular standpoint. So it's very difficult to determine. And as Dr. Liao had mentioned in the audience, there comes with some scotomas. And I only would call it a mini NION if there's a scotoma that's from that. They can't have just a normal visual field. So now we're talking about a kid who can do visual fields. It's 10 or above. But we'll certainly see in those kids this vision loss. And I don't know if it's related to the swelling or if it's actually related to their macular degeneration. But I think it's important because those are the kids that we can certainly follow from an early age group. In fact, it's the drusen early on that gives me suggestion to send a retinopathy panel for some of these early kids who are 1 or 2 years old. The question is, do the scotomas improve? Not necessarily. I haven't seen that, but fluctuations in kids' visual fields is another discussion. Thanks, guys.